Okay, good morning. Sorry we're a little delayed, but it's good energy in the room. Happy holidays. And I want to welcome everyone to the December 19th Cook County Health Board of Directors meeting. And at this point, I'm going to ask that Madam Secretary please call the roll of attendance.
Director Bott? Director Green? Present. Director Harrington?
Present.
Director Kim? Present. Vice Chair Lowry?
Present.
Director Masuda Barnett? Present. Director Ryder is absent. Director Robinson?
Present.
Director Sorrell is absent. Director Stain? Present. Director Webster Cross? Present. Chair Garza?
Present.
You have a quorum.
Thank you, Madam Secretary. The next regular meeting will be Friday, January 30th at 9 a.m. We do have one board member who is remote, and that is Commissioner Lowry. So I would like to ask for a motion to allow Commissioner/Director Lowry to remotely participate in this meeting as a voting member.
Second.
There's a first and second. Is there any discussion or questions about the motion? Hearing none, all those in favor, say aye.
Aye.
And any opposed? All right, the motion carries. I think this is mostly everyone's favorite item on the agenda, employee recognition. I'm going to turn it over to Dr. Makaitis to take us through that, because I know there's a lot of great things going on.
Absolutely. Thank you, Chair Garza. Good morning, directors. Good morning. Okay, here we go. As always, we'll start with our new hires, and welcome to Nick Shields, Chief of External Affairs and Civic Engagement, Lisa Harries, Executive Director of the Change Institute with Equity and Inclusion, Samantha Burke, Center of Excellence Manager, Patient Experience, and Simone Rush, Nurse Coordinator 2 with CIRMAC. And congratulations to our team members who've earned promotions over the last month. Anna Zonkov, Chair of the Department of Anesthesia and Pain Management, Dipte Dige, Chair of the Division of Pediatric Hematology Oncology, Taruno Wagre-Penmecha, Chair of the Division of Pain Management, Katrina Bennett, System Director, Patient Access, Michael Davidovich, Associate Medical Director, Primary Care, ACHN, Lisa Thompson, Residency Program Director, Ophthalmology, Sally Abbas, Senior Manager of Financial Assistance, Arga Smith, Certified HIM Manager, and Neela Satyana Ryan, Manager of Tobacco Prevention and Control. Congratulations. And shifting to some of our celebrations and recognitions, Providence has once again been named the Leapfrog's top general hospital for the second year in a row. Providence, one of only 2 general hospitals in Illinois to receive that recognition. The Leapfrog Top Hospital Awards, widely acknowledged as one of the most competitive honors U.S. hospitals and surgery centers can earn in safety and quality. Congratulations to our Providence team. And as always, if you're being recognized, please stand so we can applaud you. On December 17th, Cook County Health leaders were joined by President Preckwinkle and our partners at NAMI Chicago for a press conference highlighting the ways individuals can care for themselves during the busy holiday season. It was a great event. On December 2nd, our Cook County Health Office of Behavioral Health joined local leaders at the Ada S. McKinley Community Service Center in Englewood to cut the ribbon on a new Youth Crisis Stabilization Center. CCH was proud to provide the funding through our Stronger Together initiative. And congratulations to both Provident and Stroger hospitals for being recognized by the Illinois Department of Public Health for their continued commitment to advancing antimicrobial stewardship through voluntary participation in the IDPH Acute Care Antimicrobial Stewardship Honor Roll Program. Congratulations, teams. And the American College of Surgeons National Surgical Quality Improvement Program, or NSQIP, has recognized Stroger Hospital as one of 76 ACS NSQIP participating hospitals that have achieved meritorious outcomes for surgical patient care in 2024. Congratulations, Stroger team. And Cook County Health recently won 2 Healthcare Digital Marketing Awards, a Gold Award for the new Cook County Health website and a Silver Award for the new County Care website. The HDM Awards recognize the best healthcare websites and digital content across the country. Congratulations to our communications team. And congratulations to Dr. Rachel Rubin for being honored at this year's American Public Health Association annual meeting and expo with the Alice Hamilton Award. This award recognizes Dr. Rubin's long-standing contributions to environmental health, workplace safety, and public health practice. And congratulations to Pam Casara, who was named in Becker's 110 Women Hospital and Health System CFOs to Know list for 2025. The list recognizes female CFOs who bring exceptional financial acumen and strategic insight to their organizations. Congratulations, Pam. And I think that's it. Okay, I'll hand it back to you, Chair Garza. Thank you.
Thank you, Dr. McKitis. And there was one more line in the recognition of Pam where it says, "Congratulations to Pam and best wishes in retirement." So we'll come back to that in my report because I'll have more to say about that. Moving along on the agenda, Madam Secretary, are there any speakers registered to provide virtual or in-person testimony, or have any sent written testimony to be included into the record?
We have one registered speaker who will be giving oral testimony, and he also included his written statement which will be included in the record.
Okay, let's welcome the speaker to the podium, please.
His name is Jim Boyd,
Jim.
and you have 3 minutes. I'll remind you when you have 1 minute remaining and when your time has elapsed.
Thank you. Good morning, happy holidays.
Good morning, happy holidays.
My name is Jim Boyd from the Collaborative for Health Equity, Cook County. I'm a public health practitioner with 3 decades of work in local governmental public health. I've conducted research on leadership for health equity and taught at the University of Illinois Public Health. I'm retired from the Cook County Department of Public Health. Let me begin by recognizing the work of all the activists, including Immigrant Rights Task Force member Ludia Quinones, for their work successfully passing the legislation that requires public colleges and universities, hospitals, and child care facilities to set up policies for dealing with immigration enforcement that allows people to sue agents who harass and arrest them near courthouses. I'm here this morning to ask the Board of Directors about the activities of the Immigrant Rights Task Force. Dr. Mildred Williamson of the Health and Medicine Policy Research Group is a member of the task force. She has told me that the upcoming meeting of the Immigrant Rights Task Force has been canceled, and I hope you will reach out to Dr. Williamson to talk with her. At a time when residents of Cook County are being violently abused by cowardly masked federal agents, at a time when our neighbors, coworkers, and loved ones are being abducted by armed ICE thugs in camouflage, and at a time when access to emergency departments and other healthcare services is reduced because of the justified fear of residents and their prudent decision to stay at home if at all possible, it is your duty to lead. I watched a live press conference in which Director Bob Reiter strongly supported immigrants and their right to organize. I know that my colleagues on the board have worked for years to fight the structural racism that is at the heart of the criminality of Greg Bovino's ICE attacks. Across the city and suburbs, residents have organized ourselves in a network of rapid response teams. Since Tuesday, we have been confronting Greg Bovino face-to-face at Thornton's gas station in Forest Park, at Home Depot in Cicero, and on the streets of Little Village and across Chicagoland, in a courageous, nonviolent, legal, and prevention-oriented response to defend the health and human rights of our loved ones, of immigrants and Black and brown working people.
1 minute remaining.
It is your duty to take many actions within the health system to robustly defend the human right to health and health care. One of those actions I suggest is to strengthen the Immigrant Rights Task Force. In the current context, it makes little sense to have a task force that does not meet in person, that does not post public agendas and minutes, that does not gather and analyze data on health impacts of the ongoing attacks on immigrants by federal agents, and that does not recommend policies, training, and protocols to secure clinics and healthcare not only for Cook County Health Facilities, but also for private and non-governmental providers. So I ask you, first, what's the status of the Immigrants' Rights Task Force? Second, how can you ensure that the task force has the resources it needs to do the effective work that is so now urgently needed? Third, what can you do to inform yourselves about and correct the roadblocks task force member Dr. Williamson has described? Finally, I ask you to prepare a public report on the work and activities to date of the Immigrant Rights Task Force. Thank you.
Thank you, Mr. Boyd. Definitely appreciate your concern and your passion for the topic. At this moment, I'd like to ask the executive leadership if they would like the opportunity to respond, or if you need more time to look into this. Dr. Makaitis, I'll pose that question to you.
Yeah, happy to. So, back in, I believe it was February of 2025, we started a cadence of meetings, both internally and externally, and initially it was a weekly meeting for our CCH team, and every other week was externally focused. So we had invites out to labor leadership and community community organizations. And as you can imagine, as the temperature was increasing, there was really great participation, a lot of concern, of course, around what was happening and what we all could be doing about it. So really great discussions early on. And, thankfully, we hadn't seen any on-site activity. Despite that, we had developed programs and policies that we had shared. We've discussed them here at this venue as well. And there were other health systems interested. We had shared there. We had several, IHA and others that were interested in what we were doing. So our response plan was shared there as well. And as I started to say, I think because we hadn't seen activity there, we started to see some dwindling, I think, attendance in the last month or two. We've pared that back from a twice-a-month meeting to now a monthly meeting. The last one was November 10th, and we're planning for January to have the next external meeting. Nick Shields, we just announced him as our new Chief of Government Affairs. He'll be taking the lead in having these discussions. So I would encourage anybody who may not have the meeting on their calendar anymore, if they have been an invitee or if they're interested in joining the discussion, to please contact Nick. Meet him here in the room if you're here with us. We're happy to have you as part of the conversation. But we are, in fact, going to continue having those meetings. They'll be most likely a monthly cadence right now.
Nick, is there anything you want to add? Thank you. Thank you. It's nice when we can get resolution in real time, so I appreciate your attentiveness to that. That is the only speaker, Madam Secretary?
That is correct.
All right, thank you. We will now move to item 4 on the agenda, which are board and committee reports. And I guess I will start with me. The minutes of the November 21st, 2025 board meeting. I will present those and ask if there are any corrections that are needed to the minutes. Okay, so next I will ask a motion to approve item 4A, the board of meeting minutes for November 21st, 2025. Can I have a motion, please?
So moved.
Second.
I have heard first and a second. I know there weren't any corrections, but any discussion or comments? Hearing none, all those in favor say aye.
Aye.
Thank you. All those opposed? Thank you. The motion carries. Moving right along, we'll go to item 4B, minutes of the December 12th, 2025 Quality and Patient Safety Committee meeting, and I'll go to my colleague, Director Bott, who will present those.
Thank you, Mr. Chair. Quality and Patient Safety Committee met on Friday, December 12th at 9 a.m. The committee approved the following action items, which are included in the minutes. Approved 1 Sturger Hospital Department Chair initial appointment, 1 Division Chair initial appointment. Approved Sturger and Provident Hospital Medical Staff appointment, 3 appointment changes. The committee received the following reports, which are included in the minutes. Operations Excellence Dashboard, Goals other minutes that we presented for the board's consideration at this time. But before I turn it back over to you, Chair, I just want to acknowledge and just appreciate the contribution of great work of our Secretary Debbie, because her work helps us.
I'm just putting these in the lobby and I'm going right. Gonna go
And the
park in my
work,
parking space. Thank you.
of the committee in helping us move through our agenda and important work of the system.
Thank you for the recognition, and I think, not speaking, I'll speak on behalf of the board, I think we all appreciate Debbie's support to all committees and to the board as a whole. So,
I think she's currently trying to figure out how to use
we appreciate that as well. It's a tribute to you, Deb, today. Thank you. So with that, I'll ask for a motion to accept the minutes of the December 12th, 2025 Quality and Patient Safety Committee meeting.
So, second.
I have a first and a second. Are there any corrections, conversations, or comments? Hearing none, all those in favor, say aye.
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 All those opposed? Thank you, that motion carries. We'll move to item 4C, the minutes of the December 11th, 2025 Finance Committee meeting, and that'll be no one other than Director Ryder.
Thank you.
You're welcome.
Thank you, Mr. Chairman. I'm just glad our gentleman gave public comment, didn't use the actual words I used the other day at that press conference. They didn't make it to air on television, but they're available on live stream. So
Sure we
I used one of those words George Carlin always joked about you couldn't say on television. The Finance Committee met on Thursday, December 11th at 10 a.m. The committee considered the following action items, which are included in the minutes. We conditionally approved 12 contract procurement items. Request number 2 was withdrawn. There are no contracts that are pending review by contract compliance. On the screen, you'll see the contractual requests from the Finance Committee meeting whose fiscal impacts are greater than $1 million, which are highlighted for your information. We approved the proposed resolution to open a new Cook County Health Bank account at JP Morgan Chase Bank. We received and filed grant award related items. The committee received the following reports, which are also included in the minutes. The report of the October financials, the monthly report on agency reduction plan. The next regular meeting of the Finance Committee is scheduled to be held on Thursday, January 8th at 10 a.m. If there are no other questions, the minutes are being presented for the board's approval at this time.
Thank you, Director Ryder. So I will ask for a motion to accept the minutes of the December 11th, 2025 Finance Committee meeting. Can I have a motion? Thank you. Can I have a second?
Second.
There's a first and a second. Are there any, is there any discussion or corrections or comments?
Just have a question.
Yes.
Why was number 2 withdrawn? That contract, is that gonna move forward at a later date?
So that contract was withdrawn, from what I understand, was to make sure that all procedural steps were met and that it's being, I believe it's being presented today, to the full board.
Okay.
Okay. Any other questions or comments? Okay, hearing none. All those in favor, say aye.
Aye.
Any opposed? Okay, that motion carries. We will now move to item 5. These are action items besides meeting minutes. And that will be contracts and procurement items being presented by Charles Jones, our Chief Procurement Officer, and Dr. Thomas Nutter, our Chief Behavioral Health Officer.
So we got Shannon instead.
Yes, I was gonna say, good morning.
Being
played by Shannon. Not Charles Jones, nor do I play him on TV, but Shannon Andrews, Chief Equity and Inclusion Officer, and I'm standing, as you said today. The Chief Procurement Officer has one item to present in partnership with our Chief Behavioral Officer, who will be speaking shortly. This is a request to execute a contract, and it has been found compliant by the former Office of Contract Compliance. And with that, I'll turn it over to the Chief Behavioral Officer.
Thank you, Shannon. Good morning, directors. So this is an $850,000 11-month contract awarded by RFP to Sage Health Strategies. This was for putting on, the Behavioral Health Summit for 2026, and perhaps more importantly, to assist with the process of
ask for a motion to approve request number 1 under item, 5A, the contracts and procurement items. Do I have a motion, please?
So moved.
Second.
First and second, are there any, questions or comments or discussion on that? Hearing none, all those in favor, say aye.
Aye.
Anyone opposed? The motion carries. Thank you. I will note that there are 19 proposed CBA extension agreements that will be reviewed later in the closed meeting. An action is expected to be taken when the board returns to open session. These typically go through the Human Resources Committee. However, due to the time sensitivity, they are being brought directly to the board this morning, which has been done on a few occasions in the past. It's not anything new. It's not a new precedent. We've done this before. That's informational. We'll now move to item 6, and that's a report from the chair. So as I referred to earlier, our CFO Pam is retiring. Pam, I'll ask you to come up to the table, please. The tribute will begin. So, Pam is retiring. I believe this is your last month.
Yeah.
Correct? Yes. And I'll admit it to the board if they would like to make any comments, given Pam's outstanding service to the Cook County Health System, the County of Cook as a whole. I'll let that go.
So I want to thank Pam for all of her hard work. This being my 9th year, is that right?
Yeah.
Okay. I've seen us transition, the way we present, strategically deploy our finances, in a few iterations. This has been the best run we've been on in a long time, and I think, Pam, sometimes when I look back and make those comments, she's like, well, I can understand a little bit why they did this. I'm like, I'm glad you can't, because I can't. I think we're in a much better place, and, that's, Andrea Gibson had stepped in to help pull things together before Pam was recruited to come here, and Andrea did a phenomenal job, and, she helps us in a strategic way, but the day-to-day grind of making sure that this institution is here to benefit the residents of Cook. The county owes you, and I'm talking about the residents and the folks who depend on safety net healthcare. This is the safety net of the safety nets, and you put it in a strong position to continue doing that mission. I take to heart the comments you made at the committee last week, where you talked about coming from Catholic healthcare and feeling like there was, it does not holistically provide in every area. And, as a Catholic myself, sometimes the business of Catholic healthcare gets in the way of the mission. And I'm sure I'll get a phone call from somebody about saying that. But I really, really have a deep appreciation for everything that you've done to not only help us stabilize, but take advantage of the opportunities and now position us to take on another big challenge. I'm deeply grateful for that. So thank you.
Yeah, I'd like to commend her on her professionalism and also her ability to provide clarity and information. When we ask questions, sometimes we ask a lot of questions. Pam has always been able to respond with an answer, and not only an answer, something that we can understand and make sense of. Sometimes numbers can get lost in the numbers and not really know what they mean or what they stand for. Also, her sparkling personality and smile. because she always comes. She's never frustrated or fluttered by anything that we throw at her, and she will be missed, but I assume that she will be available should consultation be needed.
Absolutely. Thank you.
Anyone else? Yes, Director Bob.
Yep. Pam, just wanted to express my gratitude and appreciation for all your work, your commitment, and echo the comments of my colleagues on the board. Appreciate your professionalism, responsiveness, and dedication.
Thank you.
Wish you well. Thank you.
I gave mine to you personally last week, but publicly I'd like to say your smile and your wit will be missed.
Yeah, thank you. You just gotta warm up to you. You just gotta give them.
So Pam, I'll close it out, before I turn the mic to you. First, you say not to be understated, the county went through a lot, when you came in, COVID and coming out of that situation. And, I think I can say with the utmost confidence that it didn't come at the expense of serving people the way that we needed to serve people. And I know you were steadfast in really managing the county's finances and its budget to ensure that people got care that needed care. I think that's the best thing that anybody could have asked you to have done. So on behalf of the board, I just want to express our appreciation for your service to Cook County, and allow you to say anything you want to say.
Sure, thank you. I think I said most of it last week, but again, I'm honored to have served my tour of duty just over 4 years. I am leaving the system in a better place than it was. We've made a lot of progress. There's more to be done, but in terms of our finance team and the expertise that we have in our people now, our processes, we've improved those, and even our technology as well. So people, processes, and technology, right? And I know you'll be in good hands going forward. It will be a challenging year, but you've got a lot of good people, not just on the finance team, but the whole leadership team that will support Dr. Makaitis and make sure that continues. So thank you.
Thank you, Pam. I actually did misspeak. Dr. Makaitis.
We
We have something here that.
Right. I was trying to jump in, but yeah, so I'd be repeating everything that was just said, but. But yeah, as I started saying, I'd be repeating everything that was just said, but, Pam, thank you for closing out your career here with us. For those who may not know, I had the pleasure of working with Pam, in our last organization. We were both hospital chiefs, Pam obviously for finance and myself, CMO of the hospital. So we've had a long-standing, friendship and, camaraderie. So, and I was happy. She's actually the one who called me to come over here, for the quality role. So I'm forever grateful for that too, Pam. But thank you for all of the guidance that everyone's already referenced, and, being steadfast to make sure that we're able to deliver on the mission. It's deeply appreciated, and you're going to be very missed.
Thank you. And you've got me on speed dial.
Okay. We will take you up on that. And as is our tradition, we have
Awesome.
the picture that we give our leaders who lead. So.
Thank you, ma'am.
Thank you.
Yeah, do you mind if we just present that?
Oh, yeah, that's okay. Thank you.
You get to keep that.
Okay, and I just have one more item in my report. Also, we have publicly released the calendar of the 26th Cook County Health Board and Committee meetings, and those will be posted to the website and made as part of the record to this meeting. And you may have seen those come across recently. There were I don't know, 2,000 of them that you sent out. Yeah, something like that. Not quite that many, but And then I'll turn it over to Dr. Makaitis to give the report, from the CEO.
Okay, we'll move forward. See if that doesn't get worse. Okay. All right, so we're going to have a strategic plan and ARPA update, and then an update from our CERMAC team. So Andrea, I'll hand it off to you for the first two pieces.
Right there. Good morning, everyone.
Morning.
Andrea Gibson, Chief Strategy Officer. And first up, we have highlighting some of the strategic initiatives. I'll skip some that are mentioned in other reports, but under quality, the College of American Pathology successfully accredited the Providence lab. We had a perfect OR day through our OR optimization project, where we're working to have all cases start on time. CCDPH launched a webinar series on health literacy. They also published the Suburban Cook County Crisis System report. Under workforce, we have added 2 gastroenterologists at Provident to keep the endoscopy procedures going after a departure earlier this year. Under transformation and growth, the Robbins Health Centers, there was a campaign launched to target mothers and families. Cook County Health also launched a new Food as Medicine website, helping patients access programs that connect nutrition and medical care. Then, of course, County Care submitted the RFP to the state. Under fiscal resilience, we've been working on a project to reduce the backlog of missing attestations, to improve our billing process, and we're on track to eliminate that backlog by the end of the year. Also, as you've heard from finance, the extension of DISH funds did go through end of January, so obviously we'll be looking for that to be extended further going forward. And next up, a quick update on ARPA. We are up, I think last month we reported $95 million expended, and we're now at $99 million expended with $83 million to go through the end of next year. We're continuing our focus on accelerating the expenditures. You know, as a reminder, the personnel charges are being directed to the county corporate fund 2025. The other thing that has been going on is the Bureau of Finance finalized their review of all the subrecipients' spending pace and has we've made modifications as a result of sub-grantees awards. Overall, there were some agencies who received additional funds, almost 12 million funds, but that was reallocated from some of the other organizations who were not on pace to fully spend the dollars awarded. So with that, that concludes my report.
Thank you, Andrea. Are there any questions for Andrea on her report?
I have a general question. How many facilities do we own and operate?
How many
You don't have
facilities?
to answer now. I'm just curious as to how many facilities we own, how many do we operate or manage? What is our footprint?
For Cook County Health buildings?
Yeah, I'm not asking for an answer. I'm curious to know.
Yeah.
Later date.
So the county does own most of the buildings, but we do have a number of leased properties. Is that what the difference you're looking for? Yeah, we can, I don't know that off the top of my head, but we can get back to you.
Do we understand the implications to the reduction in funds to some of the subrecipients or grantee partners? Because it's focused on spending, but not how spending impacts programmatic implementation.
Well, I'm sure, like, it's certainly the reductions have not been well received, and it has required some of the agencies to really rethink their programmatic structure. And so the letters really just went out in the past several weeks. And so there's active conversations between the program leads and the subrecipients to kind of talk that through to figure out the best path forward.
Any other questions or comments? Okay, thank you, Andrea.
Thank you.
We'll now go to the CERMAC update, and would like to invite Manny Estrada, Chief Operating Officer of the Correctional Health Services, and Nuri Marcello, Chief Nursing Officer of the Correctional Health Services.
Good morning.
Good morning.
My name is Manny Estrada. I'm the Chief Operating Officer for CERMAC Health Services. Just a little bit about me. I've met some of you before, but if it's your first time, I'm one of the longer tenured individuals at CERMAC. I've been with the health system for a little bit over 30 years. This is my second go-around with the health system. I left in 2014 to travel the country, work for Corrections Health, and chose to come home to Cook County Health to hopefully make this a better place at CERMAC Health Services. To my right, I have Nuri Marcello. She's our Chief Nursing Officer, and I'll ask her to introduce herself.
Hi, good morning, everybody. Yes, Mary Marcello,
Good morning.
CNO for CERMAC and for JTDC. A little bit of background, like Manny, I also traveled the country working in correctional health for a good 10, 15 years of my career before I decided I wanted to sleep in my own bed in Chicago. So I'm happy to join the Cook County team, and I've been here for about 3 years I'm entering. Thank you.
And thank you for the privilege of presenting to you the CERMAC presentation for today. We'll be going through what we've done at a high level for CERMAC Health Services and look to some of the accomplishments and some of the goals that we have for 2026. The first slide gives you some statistics that we have for CERMAC. You are free to go through at your leisure. The one thing that I'd like you to note is that the fluidity of the activity that we have at the jail is driven generally by the census that we have coming into the jail. In 2023, September, of the introduction of the Safety Act, specifically for us, bail reform, really did have an impact in census. In 2024, you can see that there was a dramatic, drop in our census, and as such, some of the activity that's related to what was happening at the jail also dropped. What we've seen in 2025 is the progression of an increase in census. In 2023, we had the average daily census of about 5,400. In 2024, we went to 4,900, and in 2025 current, we're at an average of 5,700. So we see the progression and the continuation of the increase in census, and as such, the activity that we have at CERMAC is also increasing. I pulled the stats for you so you can see that we are a robust organization at CERMAC. We are a provider of everything medical, mental health, patient care service, pharmacological happening at the facility. We're really proud of the work that we do at CERMAC, and in my opinion, maybe echoed by Mary, we're one of the premier organizations when it comes to corrections health. If you can move on to the next slide, we'll start talking about some of the accomplishments that we've had for.
There's a question.
Oh, I'm sorry.
Yeah, when I look at the data, I see that the medical center notes are dwarfed by the mental health center notes, almost double. And so it appears that most of the incarcerated have some type of mental or behavioral problem.
Yes.
And I know we have a unit that focuses on both mental and behavioral health. So I'm assuming we're addressing those, but people are in and out, and there's a lot of recidivism. So it'd be interesting to see what we're doing to mitigate some of the behavior.
Yes, absolutely. I can speak to some of that now, and then a little bit later in the presentation, give a little bit more detail. Approximately 43% of the patients walking into the jail are on the behavioral health caseload. A smaller percentage, probably about 30, are on the medical caseload, and there's patients that are a combination of both. We have one of the larger components of behavioral health services in the system currently residing at the jail. We've been there for many, many, many years. We have at the facility from psychiatrists. Majority master's levels. We have some bachelor's level individuals that do the programming, but that is where we spend a lot of time allocating for our patients. When patients walk into the facility, they go through a full assessment. It's obligatory for our accreditation, but we do that really well. We assess everybody as they walk in the door. What are your medical needs? What are your behavioral health needs? What are your pharmacological needs? And we begin you as you walk into jail within 24 hours. That's why we have a really good handle on what our population is. In the facility, we categorize our patients by levels of care for both medical and behavioral health. For us, it's P levels and M levels, P being mental health and M level being medical. The highest level is 4. If you're familiar with the jail, if not, you're always welcome to come and visit us. Our infirmary, which is in the CERMAC building proper, has about 100 beds for the most acute medical and the most acute behavioral health. That's 100 and 100, 200 beds for our more acutely ill patients. We have a residential treatment unit where we house our intermediate level of care medical and mental health patients. That's about 1,000 beds. And then we have our outpatients that are scattered throughout the facility, and that's probably the remainder of another 3,000 beds. So we categorize them, those levels of care based on the building, based on the custodial classification. But we provide intensive services, both medical and behavioral health, through the continuum of the patients stay with us in jail. Hopefully that answers your question. Yes.
Do you have, do we enroll folks into Medicaid if they're eligible? Is that part of your intake process with them? And
Yes, we're first in the country in a lot of things when it comes to corrections health. Probably about 15 years ago, we began with enrolling folks in intake. As they walk in the door, we do an assessment. Are you currently on Medicaid? That's the first question we ask. Second question is, if you're not on Medicaid, are you applicable for Medicaid? And if you are, that's where we begin the enrollment for county care. We don't complete the enrollment because we can't while they're currently incarcerated, but as they leave, everything gets initiated. So as they leave the facility, they'll be able to have access to resources to be able to access health services outside the facility. So yes, the short answer is yes. And we began this about 15 years, first in the country, and we're one of the few that do it now. 1115, which I'll get into a little bit later, actually has an obligatory component to it that we're ahead of the game with. Yes.
Yeah, so I noticed that your daily census increased greatly in 2025, but I don't see change in the length of stay, which makes me wonder, people come in more, but then they just start going out. Do you see changes in the population group, more health issues or?
Yes, where we originally saw the decrease in census, the population in medical and mental health wasn't commensurate to the same percentage. So what ultimately we figured out is that we have a sicker population in the facility, both for medical, but principally for mental health. And that still is the trend now. But we continue to assess on a regular basis where we are, how we're doing, what can we do better. Looking at the dynamic of the changing population, it's our role to pivot as best as we can. It's difficult sometimes because you can't just pivot when you haven't been able to project for it, right? We don't know what it looks like next year. The social temperature, the criminal justice system, it varies and it changes, and that is what frankly impacts the census at the jail. It's just so unique to our population that we expect the decrease, right? And then boom, we saw the increase by another 20%. So it was just interesting. But yeah, we have sicker patients in the jail now. Just
Yeah, and looking at the numbers a second time, you had a total of 27,784 admissions. So that's, but it appears because of the numbers, some of the other numbers we're looking at, that there are people that leave and have to come back. Either they come back because they're rearrested, or either they come back because their sentence is not over. That's what I'm saying.
So there's some things that I really don't have a sense of. The recidivism, for reasons for recidivism, is something that we're working right now with our DOC colleagues to try to figure out. Our goal is to make sure that we provide for the patient and connect them as they leave the facility. Our hope is that from a medical behavioral health, from a health perspective, they're connected, but some folks do cycle in, and they recycle in.
Yeah, but we should have data on people that are chronically recycling back in and have mental health, and those people need to be paid more attention.
Correct, and we're doing that now with our DOC colleagues. It's trying to meld both systems together to get to that. As a matter of fact, I was on the phone yesterday with Director Gubzer, which is my colleague on the other side, trying to see how do we impact the patient's return. For example, if a patient has a higher level of care on the mental health caseload, we call them a P4. What do we do with the P4 patients? We don't want to send them out to the street because that is not giving them a place to be successful in the community. Do we have an opportunity to leverage some of the health system resources? For example, maybe Providence, maybe Stroger, maybe directly into the ambulatory sites. We do some of that now, but we want to do it a little bit more fluid and more structured, so we can at least have that positive impact on patients.
Yeah, what occurs to me is probably already in place is that these are people that are probably involved not only in terms of both medical and mental health, but these are people that are involved in the criminal justice system.
That's correct.
So there's also this other layer, the degree to which we can cooperate with some of the other entities that are involved.
We have participation in the various courts that are out there. For example, we have diversion programs that we embed our folks into, that we try to make sure that we get folks somewhere else if they don't need to be in the facility. We have drug court where we have our folks that are involved in where they're enrolled mandatorily at the facility. Some are court ordered. There's voluntary opportunities for us. We have a unique opioid treatment program for our SUD population, substance use disorder, where folks, where they're on the program in the community on methadone and Suboxone, we continue that. And we also induce or enroll folks while they're in the facility. So we do our due diligence to try to connect folks while they're in, and then continue with that connection when they leave the organization.
Just a quick question. You mentioned people coming in maybe are sicker, but, you know, the number of healthcare requests that form in nursing encounters are way lower in 2025. So what do you think?
Sure.
I can speak to that one. When we looked at some of the data, it really was our mentally ill population that I tend to worry about a little bit more. They typically don't follow our process. Maybe they're hesitant to fill out a health service request or ask for assistance. For that reason, we do rounds on the unit, and we try to ask them verbally, is there anything you need, anything you can do? But that physical data of filling out a form, that becomes a barrier to access to care. So we try to work around that, but my belief is that's what's occurring.
From just conceptual, our patients access services via the health service request process that Mary is describing. So it's not a matter of, I want to call the doctor and go see him. This is how you access. And to Mary's point, some of the obstacles that are there are there. But we do our due diligence. We have nursing 24/7 in our intermediate and our infirmary level of care. We have a presence in every living unit every day, minimally 8 hours a day. In the more extreme cases, 24 hours a day.
I have a question. If I'm staying with you all and I have a moment where I need behavioral health services, but I can't, I'm also in a space where I may not recognize it. Is there a health service request route that maybe those around me recognize that I'm in a different mental state can actually trigger that process, or do I have to put it in myself?
Yeah, so our workarounds for that, we can access healthcare even through the medication path. So when the nurse goes to give a med or see something, we can absolutely bypass our system and get them in front of a provider as quickly as possible. And even the turnaround time for health service requests, the standard of care, we try to see them within 24 hours, and we absolutely meet that goal, which again is rare in a correctional setting, but we're able to do so at Cook County Jail. Thank you.
The other component to this is DOC they're our partners. You know, they wear a badge, I don't. That's the only difference, right? No, that's not the only difference, but that's the big difference. They can trigger access to health services based on their observations, and that's 24/7.
That's great. Thank you.
What incentive do you have to connect individuals who are being discharged that have a behavioral health to resources so that they do not return? What is the incentive?
Well, we have a couple of things that we have going on. Our colleagues on the other side, DOC, have an incredible network, as do we. We leverage our own health system as best as possible. We have ambulatory centers throughout this county of Cook. We have some familiarity with it. I worked with ambulatory for many years. I was a regional director for ambulatory, so I'm familiar with it. Our first goal is to try to connect them to whatever services are applicable. Before patients leave, we have a discharge plan. Let me just in general say what it really means. As a patient walks in, we start assessing what are your needs, because you're going to be leaving. 90% of the folks that walk into the jail are going to be back in a relatively short period of time. It's a small percentage that get sentenced in the jail and/or to IDOC. So we're prepping for them leaving. We have 6 social workers that are on site that do that care coordination. I'll call it care coordination, and they start looking at what do you need, where can we hook you up. We have, in conjunction with our SGD program, peer counselors that are also looking for folks that have a need when it comes to substance use disorder connections, either programs and or support. So we have that embedded. Now, we can do that a little bit. And a little bit later in the presentation, you'll hear about 1115. I'm really excited about 1115, and you'll hear why. Because that really opens up the door, because the population that we service more intensely with those reentry services are seriously mentally ill. You'll hear me say SMI, that's serious mentally ill, and our folks on the chronic care panels. The folks that we've identified that will need some follow-up care. We're looking to expand that to everybody. And 1115 will hopefully, knock on wood, allow us to utilize and leverage resources for that.
The question that I asked was, what is the incentive? You told me about what you're doing, but you didn't answer my question.
Oh, I'm sorry. I can't speak to the incentive other than to be better for the patient. Some court-ordered programs obligate the patient to go through certain things. We can only offer, and that's the reality of what we have with our patients. We offer. We can't obligate. We, like anybody else, the patient has a right to refuse. A patient in the jail can say, I don't want your medication. I don't want your services. We obviously clinically and from a behavioral health perspective, take a look at what's in the best interest of the patient, and up until the point, the patient has to be participatory in the programming and the stuff that we do. My hope is that folks, our patients, see the need and what we've done to begin the services, and would hope to continue with some of the stuff that we've outlined for it.
Well, the average length of stay is 37 days,
Mhm.
so you don't really have a lot of time to make an impact. I mean, most you're able probably to do is an assessment if the patient's willing to engage that way, but then also follow your treatment plan. So it's not a lot of time. I was going to ask you about Matt, but I see that's in your 1115 waiver update, so I'm curious about that, but I'll let you continue in the flow of the presentation.
Yes, the period of time that we strike where the iron's hot. I referenced our intake. Our standards for our accrediting body allow us to do one of two things. We can do a full assessment on the patient within 24 hours, or we can expand it out over 14 days. That's intentionally done for facilities like a temporary correction, because it's difficult to do those assessments on patients. We have chosen intentionally to take the more stringent route of doing everybody within 24 hours. We have a license, an MD, and a prepared mental health professional in intake as the patient walks in, with the opportunity to assess them. That's the beginning. After that, we follow up with the patient in that short period of time. We hit them, and we hit them hard with intensive, just trying to figure out what your needs are. And we do a really, really good job. I'm not saying we're perfect, but we do. I've seen other intakes across the country. What we do, and I don't know if Mary can echo this, but we do an incredible job there.
Manny, I would never even begin to try to debate that because I saw a report, and I'm sure that since this is your, area, I just want to reference it. It was published just, I believe it was last week, and the headline was "Ignored, Misdiagnosed, Left to Die, Illinois Prisoners Held in the Hands of a New Provider with Shoddy Track Record." Did you come across that report?
Yes, that was for Centurion, I believe.
Yeah.
Yes.
And so the difference is that many of the correction systems in the state subcontract. That is not what Cook County does.
Correct.
So you're, like, based on what I read and based on what I understand, this is a way more comprehensive approach that the county uses, Cook County uses in working with detainees, otherwise patients in the system. I'm interested in your reaction to the report and how you see that, how you see the county's work as it relates to that report.
But you can start.
Yeah. That's very interesting. From our background, both Manny and I, we worked in the for-profit sector with private vendors. And unfortunately, in those areas, there is a price tag for each patient. It's a profitable market. The big impact when I joined Cook County was to see the difference. The fact that we see patients within 24 hours of them stepping foot in the jail, that was mind-blowing. We have CT scans, all the infectious disease, all the stuff that we offer. I would tell Manny, I'm like, who pays for this? How do we go about this? Why do we do this? So it's been a learning process for myself. But the fact that we're able to do that, it really is a change compared to the private sector where you do put a price on the patient. If they're not on MAT, why should we start it? We're choosing to initiate MAT in our facility, and we have been doing so for many years. To me, that was impressive because a lot of facilities, again, if they don't need it in terms of they're not on it already, why should we start that? So it is a very contrast, different black and white.
I think that's an important point that we as a board need, I think, understand, one, and very much appreciate, because it's not just about the lawsuits, it's about the Illinois Department of Financial Professional Regulation, Department complaints that come in from detainees or patients on their belief that the lack of health care that they experience is detrimental. And I mean, the report's out there publicly, but I appreciate this report this morning in light of reading that report just last week.
If I could add, just from a recognition standpoint for the programs that you all have at CERMAC, right? Your MAT program was recognized in CCH, which is the governing body over correctional care, in their national journal as kind of a high standard thing that they thought should be highlighted nationally as a leading program.
Thank you. And one of the things that you'll also hear in our goals is we're accredited for jail standards, which is the overall accrediting for correctional organizations. We're accredited for our OTP program since 2009. And this year, in 2026, our goal is to get accreditation for our behavioral health component, our service line. That'll give us all 3 accreditations for NCCHC. Now, that just means you're accredited, right? For us, it means that we're meeting the constitutional requirements minimally, and for us exceeding, both for us and for the Juvenile Detention Center. So I can't forget about my friends over at Juvenile, because we do those folks too. And echoing what Mary said, I've worked on the other side of the fence. I have colleagues that work for said company and other companies, and there is a difference in what we do here and what they do on that side.
I just want to go back to my colleague, Director Robinson's question about incentives. I know that the court system has diversion programs that if the individuals adhere to, let's say, a 21-day program, that they can be diverted from repeating or recidivism back into the system. So I know those programs are in the county judicial system.
Chair, the reason why I asked the question, because I'm not questioning how good or bad they do something, but I'm trying to understand the purpose of the organization to house people until they are sentenced, or is the purpose of the organization to try to redirect them as they leave so that they don't return? Those are very different objectives, and if the measurement isn't being captured as the recidivism, then if that's the goal, then we'll never meet it because we're not measuring it.
So I think, I'll take a shot at it, and I'll leave it to the professionals to speak to it, but I think number one is, what is the scope, which we're hearing, the scope of what the system can do, and what can it do in 37 days? I mean, I don't know that that's the responsibility of these folks to figure that out in 37 days. It's a bigger issue, which I think Manny was referring to. It's connecting with the correction system, and then making sure those pathways into treatment when they leave the system are there to support them in the community. That would be my sense of it, having some experience working with the juvenile population.
I think that's spot on. I think, from a broader recidivism question, Manny and team aren't treating every single person detained in the jail, so there is, it's a subsection, right? So when it's healthcare related, that, whether it's a mental health issue, that's why they're getting arrested again after they go out to the, I mean, that would probably fall under the team, but there's a whole, list of issues that aren't healthcare related that is really more in the DOC realm than it would be for Manny. I mean, I'm sure we could get to those who are coming back and being retreated again from a healthcare perspective, but that's not going to capture the entire kind of recidivism question.
Yeah, that's what I wanted to try to get a better understanding of, because the total number of new admissions was 30,000 in 23, 25,000, and back up to 27,000. But based upon what I'm hearing, this might not be a unique number because people leave and they come back. And so if they come back, then they're a new admission again. Is that the number, or is this a unique number?
It's individuals, it's not unique. So that would be a different number.
Okay.
And I guess to everybody's point, are we tracking folks that come in recurrently? With DOC and us, we're looking at that. There are some things, to Dr. McIda's point, that we can directly access and directly impact, but there are some things that collectively need to be done at a global level. The criminal justice system needs to, I would suggest, we need to take a look at it from a criminal justice system, diversion program, the drug courts. I've worked at different organizations across the country. Miami, for example, had a really intensive diversion program. Judge Lightman in Miami, which he came to Chicago to see what we were doing and using examples across the organization. So yes, but the system in its entirety, we have a new chief judge that hopefully will be looking at this with different eyes, also hopefully impacting some of that.
Yeah, and I want to lift up one thing. It's not a question, it's an observation. Yes, sir. That you had the lowest percentage of nursing healthcare requests closed within 7 days in 2025, excluding December. And so obviously you're doing some good work. So I don't want it to be all negative.
No, thank you. We appreciate that.
It's a lot of work we put in there.
So one of the things, I think, welcome back, this is the second time we've gotten a chance to connect. The last time you came here, I mentioned, I know IDOC as well as CERMAC had, I'm not sure if they still have it, a program where people with chronic illness can be set up with an appointment, which ties into a comment I think Dr. McIdas made, I want to say in March of this year, when you talk about behavioral health, how many of them are we connecting to our system once, once they leave your space, or IDOC, but your space too. But I know that CERMAC, in fact, had a program where, speaking just from being at the Core Center, people could come, they were set up with an appointment before discharge, like you said, but they also, speaking to the first line you have about case management in the 1115 waiver section, they also had support with getting IDs, like getting those things in. It's a 37-day average stay. However, a lot of those people don't even have it. They didn't have it before they came in. And a lot of people, that played into whether or not they actually attended their visits. So I'm wondering if you can parse out, of course, there are other variables there, like a diagnosis, but is there decreased recidivism in those people that are discharged to places where they have the social determinant of health wraparound and maybe care for, behavioral health or HIV or whatever kind of clinics you have those connections with?
We struggle with that a little bit right now, based on the volume that we have for patients. I think we do a really, really good job of identifying the needs. The work that we will hopefully be able to impact is the connection, the reentry. that is specifically what the 1115 we're hoping is going to help us do. It's not that we're not moving forward with what we have now, but the program is geared towards reintroducing reentry services, case management services, everything that you described more robustly. So we do it now with the patients that we can, but there's an opportunity there, and we hope to make a positive impact on that.
But also to be clear, notwithstanding the 1115 waiver, which we want to get through the presentation, because I know we're asking questions that are already, I'm looking ahead and responding to questions that you're already going to present on. But it also depends on what the resources are available in the community.
Correct.
You don't control that. Correct. We know there's a shortage, a significant shortage in behavioral health, mental health support. So you can only be as effective as what the ecosystem will supply. So with that, let's continue before we do your presentation for you by asking questions.
Yes, sir. Thank you.
Next slide. All right, we're going to talk about accomplishments. But the biggest takeaway is every accomplishment that we have on here creates a platform to have these crucial conversations. So that's why we put them on the slide, but it also opens up that opportunity. Dr. Mikaitis took my thunder about our NCCHD accreditation. We are accredited. And again, that's just telling the community that we're doing the best that we can to not only meet the standard of care, but to go above and beyond when possible. And that's something, at least from all parties, we will continue to strive for, including the mental health accreditation for 2026. Dr. Augustine did have a fireside chat with President Perkwinkle, and again, it's focused on those conversations. MAT, our behavioral health challenges. The more we talk about it, the more we can brainstorm opportunities of what we can do differently. Going on to Manny Estrada, you were recognized this year with the Health and Medicine Policy Research Group Health Award. And again, it's given to individuals who have that visionary leadership to make an impact on the community and the health equity across Illinois. So congrats to Manny. Dr. Ennis, Dr. Ennis, he was elected with the Board of Directors of Illinois. He's also our lead for MAT at Cook County CERMAC Health Services. And again, it creates that platform of what can we do differently? Is there anything more out there that we can do? So we're ecstatic that he's part of the board to make those changes. And then Dr. Zayowitz, part of CERMAC. Publications are on these accomplishments because, again, we want to talk about these things. He published incarceration is a key driver of racial disparities in community-assisted MRSA outbreaks across Cook County Health. Again, this was in July for the publishing article of epidemiology. Next slide. This next accomplishment is a huge win for CERMAC Health Services. Again, as I spoke to briefly, every county typically has a third-party vendor. It's not always government-run. So for us, it was important to network with our fellow counties because they're dealing with the same struggles that we are. So we were able to host our first Midwest Correctional Health Conference. This was a free conference where we talked about recidivism, MAT, transgender care. We offered CEUs, and it really was such a great outcome. We had about 120 attendees, and this was the very first one. And again, this was free to nursing, medical, and local jails. Dr. Conan O'Brien, he presented at the 41st annual meeting for the International Society of Traumatic Stress Studies in alignment with the impact of trauma-informed systems transformation in the juvenile detention system.
You can't let Conan O'Brien just sort of fly by.
Oh, I am so sorry, Mr. O'Brien. I apologize.
We have multiple personalities.
We do, and especially if you work in corrections, absolutely. Our next presentation, ectoparasite. This one people do not want to talk about, but it's a reality of where we work in. We do have lice issues within the jail, and it's not just Cook County Jail, it's every jail. So our team developed a poster presentation, talked about what worked, what didn't, and these are topics that when you looked at evidence-based practice or research, it's not there. It's not in the literature. We know what we do in the hospital. We know what we do in the community setting. But in the jail, it's not information that's freely shared. So for us to write this poster, present it to Lori Children's, Northwestern, and then get an invite for our annual NCCHC accreditation, that was a milestone for us, and we hope to continue to do that. We were also able to roll out 3 naloxone vending machines throughout the compound, strategically placed in the areas where we know there's going to be patient traffic and employee traffic. Division 10, 11, as well as Post 5, which is the main entrance. And then lastly, our juvenile detention center did get an ongoing just recognition for their accreditation and the work that they do with the juvenile youth across the Cook County area. Next slide.
Now we've connected some of the other presentations here to our pillars for our strategic plan: quality, safety, and experience. Our goal is to provide for our patients, members of the community, access to the highest quality of care, dignified for our patients here, and that are consistent with to support our patients' needs. That is what our goal is. Ultimately, we want to continue with our national accreditation with NCCHC. We've said it a couple of times. The jail standards, OTP, and 26 will be sitting here next year telling you we've had all 3. With NCCHC, when you get all 3 accreditations, you're considered part of the pinnacle organizations that they have for corrections health across the country. That is what our stated goal is for this year, and again, we'll be here next year telling you that we've achieved that goal. We want to improve the clinical performance by reducing the average turnaround time for medication orders. If a patient comes into the jail and they're on medication, we begin them at intake. We don't wait 2 days later to figure out what you were on. We validate, we verify, and we begin you on medication. If during the course of your stay, your medication has to be adjusted, we change that medication and provide it to you at the next bill pass. We have bill pass twice a day minimally, but that's an incredible undertaking based on some of the volumes that we have for medication over there. But our goal is to get better. We don't want to remain stagnant. Yes.
Interesting about the medication. You probably don't do it now, but can you look at those who have behavioral health issues when you do your intake and see who's actually on medication versus who isn't? I think that may be very interesting and telling as to what can be done possibly on the outside to prevent some of them from returning.
We actually do it to a certain extent. We have access to outside records real time, so we can pull up their profile if they're enrolled to see what is out there. Obviously, we take it on self-reported, but you're absolutely right. There's an opportunity there to do a little bit better. But very, very valid point.
That would be very interesting for you to present that.
Agreed. In conjunction with NAMNI and the Cook County Judiciary, we implement assisted outpatient treatment for our mentally ill who are been charged with misdemeanors. Again, working on trying to figure out what we can do with diversion. We implemented our behavioral health management unit. We have a special population in the jail. Some folks that are diagnosed with mental health conditions, other folks that have behavioral condition that is more DOC driven. We've created a specific unit this year where we house those patients. We're looking to augment and open up a secondary unit for our more aggressive, violent patients that we house in Division 9, and we're looking forward to getting that for this year. We're looking to implement a forensic fellowship at Cook County Jail. People are chomping at the bit to get into us, to learn, to see, to use it as a training ground. So Northwestern has agreed to give us 2 fellows. We're looking to implement that in 2026. And we have, as I referenced earlier, CT diagnostic services at the jail. Right now, we offer it 1 shift. One of the things that we find ourselves having to deal with is sending folks off shift to Stroger to get some of these diagnostic services. Our goal is to try to increase that coverage to minimize patients going off-site. Our goal, our role, is to keep patients on the campus as best as we can in a safe environment. That will hopefully allow us to do that a little bit better. So more to come in 2006. Next slide, please. A sensitive topic, but nonetheless a topic that we will and continue to deal with up front. We want to be a place where people want to work. We believe that we run a tremendous program. We loud and proud with our people, our colleagues, our networks, and it's resonating with what we've done with some of the work that we have. I apologize for some of the tabs were a little bit off, but medical. Our current vacancy rate is 20%. We've had some attrition. Some of our senior leaders have chosen to retire. Hats off to them, they're enjoying life. We're looking to have a goal of 5%, and I believe we'll meet that goal of a 5% vacancy rate for medical. Mental health, I'm going to call out particularly. Right now, their vacancy rate is 23%. Their vacancy rate at the beginning of 25 was 40%. That department, with its leadership, have done a yeoman's job, a tremendous job in recruitment and retention, where they're at 23% now. We're looking to get down to a 10% vacancy rate, and I believe that's attainable. We've hired 4 psychiatrists at the jail. 4 psychiatrists, where the rest of the systems are struggling to get any of the behavioral population. We've structured that department to better align to do the work we need to do, and it resonates with people coming to work with us. They want to work with us. Patient care services is currently at 36% vacancy rate. That vacancy rate is real. We know it. We feel it. We're doing our due diligence to get folks off agency and onto our roles. We had a hiring fair where I believe we're going to impact this. It was a CERMAC specific, a correctional health specific hiring fair this week, where we were able to hire.
The total was 38 out of our 42 vacancies. First hiring fair again, CERMAC correctional only. It was a huge success, so we're very proud of that, and hopefully we can make a dent on that 36%.
We're shooting for 20%, and that's our goal. We're, again, doing our due diligence and recruiting for folks to do everything we need to do. For mental health, I hit a little bit. We are looking at not only just recruiting people, we're looking to take feedback from staff that we have. There's an engagement survey that's going around for all of the behavioral health service lines across the system, specifically for us. We'll be looking at trying to incorporate the feedback into the culture change that we have going out at the jail. It's a difficult place to work, and sometimes we struggle with that term institutionalization. You hear when it's referenced to patients, but we internally have to take stake in ourselves to make sure that we don't become institutionalized, because it is a difficult place to work. There's a lot of chaos, there's a lot of violence, there's a lot of anxiety.
Trauma.
We need to be able to not take it as the norm and continue moving forward, and that resonates in the culture that we have, and we'll be looking at how do we do that better for our staff. We need to support ourselves, and we need to support our people. Yes, ma'am.
One of the things that, I'm sure you know this, I'll just put, after every pandemic, we just, right, for the next 10 to 15 years, there's an increase in mental health related stays and things like that. So I'm sure if you pull your numbers of why, and you saw it went up, then it went down because they changed the rules. The rules didn't change, but it went drastically up again. And then your team members that were functioning in the department were overwhelmed, and it was just an escalation, right? So the first 1 to 3 years after the pandemic, it's actually going to accelerate after the 3rd year. So I think that plays into a lot, and we definitely want to keep it positive, but and also recognize every 100 years these are the paths that we as humans go through, and there may be some need to consistently plug the spaces, especially in mental health, because we patched them. It's the 3rd year where it actually accelerates, and then there's an intergenerational process that you're going to go through after the 10 to 15 years. So, yes, and sending you all the positive energy. So thank you for what you do.
Thank you. And then along with our mental health programming, it's great to have individual treatment, that's great, but programming for our patients is what we're looking to increase across the facility. Then supporting medical in the recruitment and retention. I referenced that we had attrition to both our leads, with the exception of Dr. Augustin. She couldn't be here today. She's off on PTO. But our two divisional chairs recently retired. We're looking to actively recruit and hire folks to take on this challenging role at the facility. Interesting, a lot of folks don't know this. We have a huge public health infectious disease arm in the jail. We have our own infectious disease attending and nurse epidemiology supporting that because we are an extension of public health. We are an extension of ambulatory. We are an extension of all services for the system in the building in itself. So more to work on that, but it's supporting that department. Next slide, please.
For transformation and growth, one of our largest initiatives is the medication path. We talked about this briefly, but the amount and the quantity of the medications that we give, I forgot the number, but it's anywhere between 500,000 to 600,000 in a month. That's a huge, huge amount, larger than any nursing home combined that I've seen. So we want to make sure that we pass out the medications safely, the right person, the right time, the right date, and whatnot. So we've been trying to roll out barcode scanning, and I know in the hospital that's very common. There's evidence-based practices that show why we're turning to barcode scanning. But in the jail setting, that could be a challenge for multiple reasons. Connection, the cement walls, all of the fun stuff. But we have been successful in rolling this out within 2025, and we want to continue this in 2026. It does, there's a time requirement in which does increase our time for the med pass. So we know those challenges are ahead of us. Despite that, we know that this is best practice and it's a safety concern, so we want to pursue this as best we can. Also telehealth. We have been rolling out telehealth across the compound, specifically within 3 specialties. Again, we want to decrease the amount of transport with our patients going off-site. So if we can do that in-house where it's safe and secured, it's better off for everybody. We just have to expand on this, and we hope to in 2026. We also spoke about MAT, and we know that we have this program at the jail, which is fantastic. But our goal is to grow this out. We know that we have a waiting list, and we want to make sure we reach those people on the waiting list. But of course, that requires more time, more providers, and as well as more nursing. Slowly but surely, we're getting there. But this is definitely an opportunity for us to expand our program. In conjunction with NAMI and the judiciary system within Cook County, we have implemented assisted outpatient treatment for the mentally ill, and especially for those that we know are misdemeanors, and we can help in some form or another. And lastly, with the North, as Manny talked about this, Northwestern, the Forensic Psychiatry Fellowship, that's something we're looking forward to. Again, just expanding our services and spreading the word of what we do within the jail is definitely one of our goals. Next slide.
And for me, this is probably the most exciting work that we're doing right now. It's a little bit nebulous, and I hope to have answers for questions that you may have. But a lot of what's happening around 1115 is contingent on the layout as agreed to by CMS and state HFS. So the 1115 waiver it's an opportunity for it's an opportunity for services utilizing Medicaid as a funding source. For us, particularly at the jail, it's an opportunity to bill Medicaid for services that we formerly have not had an opportunity for billing at the correctional level.
Sorry to interrupt. That's because when the detainees enter the system, they lose their Medicaid benefits.
Yes.
Correct.
They're either suspended and/or stopped, and that's made a determination at the state level. Every state, every county has a different process, but yes, you're right. So in essence, what we're looking at now is for reentry services for a particular group of people, for a particular group of services, looking at billing. And at a relatively high level, what we're looking at are for folks that are utilizing case management services, what we described as our social workers, quasi-case managers, medication-assisted treatment services, what we do in the facility, and what we do in connection and connecting our folks for reentry services. Both of this is during the 90 days prior to discharge and connecting them into the community. Prescription medication. We medicate patients while they're in. You heard the numbers, you heard the process, but we also have per 1115, and we've been doing this, providing a 30-day prescription for a finite group of patients that we identify as needing medication. We will hopefully be doing that more robustly. Diagnostic services, x-rays, CTs, lab tests, that we do 90 days pre-discharge, and again, utilize it for connection, and their health-related social needs, support for housing, food, transportation, employment. We're one component of the 1115 waiver that's looking specifically at the jail, but we have other components of our system looking at housing, looking at food and securities, looking at other social needs that we're going to be trying to connect with our patients. These are going to be services that are available for the Medicaid eligible. So the fact that we're doing Medicaid enrollment at intake is a tremendous benefit of us. We're, again, unique in that across the country. Not everybody does it. With 1115, you're obligated to do it. So we're ahead of the game. And it's, again, for services that are expected 90-day pre-release. So we reference the average length of stay is 45 days. Whatever the number is, it's less than 90 days. So a good portion of our patients we should be able to leverage to be able to augment and support what they're doing.
When will you be able to start billing?
I'm sorry?
When will you be able to start billing Medicaid?
We don't know. We're still having a negotiation. Thanks to Andrea, she was here earlier today. She's helping us head those conversations. The state is currently working with us on what does it look like? What is the bill going to be incorporating? How does it look? Finalizing the nuts and bolts of what it looks like. If I were a betting man, I don't bet because I always lose. In any event, I would say probably latter part of 2026, beginning of 2027. That's my gut, but I don't know.
Medicaid enrollment's half the battle, because if they don't
Yes.
have that when they leave, then that's one more door, multiple doors that are closed.
Correct.
In terms of accessing care, because they don't have the benefit.
Correct. The other unique aspect that we have here, again, which is, again, the system is incredible here. Not just because we're sitting here, because it is. We have a unified medical record. We have access to patients' information, as do our colleagues, within the system, and in some cases outside the system, to medical records. So that's the other component that needed to be incorporated into the 1115, and we're ahead of the game on that. Again, I'm excited about this. We have conversations with our colleagues because we talk amongst each other. The big jails, we talk on a regular basis. LA County, New York, Atlanta, Minneapolis, Harris County, and we compare notes. We're better positioned and better prepared, hopefully, again, with the goal of making this a successful rollout.
Manny, first question. On the future covered services, does this also, if you think about case management or health-related social needs, the opportunities to connect to public health? So are there public health services, given just our ability to connect public health and clinical services, if we can embed that into this?
Yes, our
That
goal
is
is to
service.
embed as much as we can, yes. And
Yeah.
public health, Dr. Yoshi, again, I said it in the previous presentation, he's not only a friend, but he's a colleague. We work with him tremendously well, and we understand. His folks came out to visit us a couple of weeks ago to just get a better sense for what it is we do. We're an extension of, and we'll look to make sure that we leverage every opportunity for our patients.
Great. And the other question is, as we think about diagnostic services and the capabilities that are growing on remote monitoring and some of these devices that can help get a tighter handle on what's happening with patients and their values, is consideration of can we incorporate some of those capabilities?
We're looking to leverage all technology that's available to our patients outside the jail. So if it's available at the hospital or an ambulatory or public health, we're looking to be able to access it in the facility. There's some real limitations that we have in the correctional facility. Safety and security dictates some stuff. For example, you can't have a cell phone in jail, and some of the modules, some of the technology incorporates kind of a cell phone type thing. Those are the things we work closely with our DOC colleagues, but they've been receptive and responsive to be able to do what we need to do. But those conversations are ongoing all the time.
Yep. And then in the transformation piece you just talked about previous to this, any thinking about the use of AI in a responsible way to help drive some of the intervention, care gaps, prediction?
I'm going to defer to our system leadership on that. We look for direction.
We don't have to talk about it now, but just
yes,
It's out there.
Yeah, it's out there.
But
It's out there.
Yeah, technology.
And I'll just end by saying just a deep sense of gratitude and appreciation for all the hard work that Sir Mac and you all lead and the team does.
Thank you.
Yes, thank you. Thank you. And in essence, that is our presentation for today. Our goal is to do and provide for our patients with the understanding that our patients are coming back. Our patients are your patients. Our patients are with us for a short period of time. 90+% of these patients are coming back, and they're coming back in a relatively short amount of time. To the point that was made here by all of you, we want to make sure that we impact in a positive way. Along and in collaboration with our DOC colleagues, our goals are the same. To minimize recidivism as best as we can, understanding and doing the deep dive on what we can do. But ultimately, we're here to serve our patients. And we thank you for the support and the opportunities to do the work that we do. We are unique in that this system supports us. And it resonates, and it's demonstrated in the work that we're doing for you and for our patients. Thank you, and I'll open it up for any additional questions.
I suggest we thank you for the job that you're doing under trying circumstances, because you're working with a justice-involved population. And so many of your patients come back again and again and again. And so the work that you do is critical, but also the fact that there is a place for them to come and that you show compassion and care and you give them the best treatment you can. I just want to applaud you.
Thank you, Director Harrington.
And also applaud you for recognizing that the team members that are serving this population also will need some service of their own and some intervention of their own, so planning ahead, because, again, this, don't want to hear it, right? At the third year, you get an increase, actually, after a pandemic. So, yes, they left because they're professionals and they know it's coming, and being able to plug that and provide support for yourselves and the community.
Thank you for that. And I guess in closing on the report, I too want to thank you both for the work you're doing, your team as well, and for coming to present. I did run this by Manny before offering this up, but I know there was a lot of interest. I think it's because it's, in part at least, one of our most unique areas of care provision as kind of the provider side of the organization is what they're doing at CERMAC. So if there's interest in going to see it, Manny would be willing to arrange tours for everybody if you guys want to go and kind of see what goes on.
Yeah, I would say let's be intentional about doing that. I'm interested. It's a very robust system that is not replicated anywhere I've seen, including in the state of Illinois. Those places can learn that you talked about across the country, but we have places in Illinois that can learn from it as well. So, Nuri and Manny, thank you for the presentation. But thank you.
You're very welcome. And it's a sincere invitation. You're absolutely welcome. We're really proud of the work.
Yeah, thank you.
Thank you.
Thank you.
Thank you. Okay, Aaron, that's going to be tough to follow up on, but we'll go to informational reports. Managed Care Committee metrics reviewed by Chief Operating Officer for Health Plan Services, Aaron Galena.
Good morning, directors.
Good morning.
All right, we'll start with our usual membership. We are at 395,000. As of December, that's relatively stable. We've had some slight decreases this past few months, but generally have been in a somewhat stable environment. If you go to the next slide, this shows some of our impacts of redetermination rates and Cook County choice enrollment, so the two kind of underlying dynamics that drive some of the membership trends. So you can see READY retention rates have also been fairly stable around the 86, 87, 88 range. And then the Cook County choice enrollment, which is how many individuals are coming into Medicaid managed care that are making a choice of health plans, are choosing county care. That's a really key metric for us that we've been tracking because we think it's reflective of our reputation, our marketing, and our overall member experience. And that's a number that's generally been climbing over the past 2 years. So if we look back 2 to 3 years ago, that number was around about 20%. We've driven that up now to be pretty consistent with our market share in that 33% range. The next slide shows where we're at in terms of market share. So this data is from the state and through October. We continue to be, by far the largest plan in Cook County. Our market share is at 34.9%, so that increased since July. In July, we were around 34.7%, just after the HBIA coverage loss, but we've seen that now increase a couple points up to 34.9%. The next slide shows some of the dynamics that are underlying that market share data. So on the right-hand side, you can see the overall enrollment in Medicaid managed care in Cook County is continuing to decline month over month at a pretty steady pace. Our membership's a little more variable on the left-hand side, but generally outside of that HBIA coverage loss period in July, which is that big drop down you see, our membership's been a little more flat than the overall market. And so the result of that is that we're slowly but surely gaining market share each month. This slide rolls forward now into our new budget year. So December of 2025, we need to update our title to say fiscal year 2026. But the data is updated here. And so we're starting in a good position compared to budget, given some of the overall redetermination rates and some of that choice data outperforming what we projected in the second half of last year about the time we were doing the budget. So I think we're starting in a decent place. Obviously, there's a lot of dynamics to play out over the course of this year. So we'll continue to share where we're at.
Aaron, I have a question. Given the fact that County Care was the only plan in Illinois that received 4-star rating, is that an opportunity for the state to maybe reconsider the allocation of patients that go to County Care versus some of the other plans that didn't achieve those quality ratings? This is really supposed to be a value-based driven system of care. That's more of an opinion, I guess, I'm asking for.
Yeah, absolutely. The other key driver on membership is for individuals that come into Medicaid managed care but don't make a choice, the state then auto-assigns them into a health plan. So they do base that algorithm on a number of factors, including geography, past PCP relationships, but one major component of that is quality scores. We do get a significant share, a higher share than other MCOs because our quality is better. So we didn't necessarily have a chance to increase the amount of that share, but we were able to sustain the higher share that we've been getting.
I would imagine it would be considered in the RFP as pending determination, and we'll know in the next several months how that goes. But that was a consideration within the RFP, I think, right?
Absolutely. We certainly highlighted that rating throughout our RFP response. So I think, I think from a quality perspective, we're well positioned for the RFP process. The next slide goes into our operations metrics, mainly around call center and claims and encounters acceptance rates with the state. these measures have continued to perform within our standard kind of service level expectations. Of course, we're continuing to tweak everything from our call center scripting to outreach and engagement with members as we are navigating a more complex environment right now, and are getting a lot more questions around what some of the federal policy changes will mean for members. So we're trying to continue to tweak information that we're sharing with members to try to help best support them.
There was a steep decline in the volume in November, almost 10,000. But I'm assuming because there's only one, it's not a trend, but you know what may have happened or what may have caused that.
No, we do see definitely some seasonality in some of these numbers. Open enrollment period, the majority of our members go through open enrollment with the opportunity to make a choice in kind of that early October timeframe. So, you know, part of that I think is just open enrollment dropping off, but there's definitely some seasonality to the numbers too. Next slide shows inpatient admissions per 1,000. Here you can see prior period versus current. One thing that, you know, I think we've sort of consistently seen over the past 12 to 18 months is a moderate but progressively increasing inpatient admissions per 1,000 rate. That's reflective of sort of the changing population dynamics within the plan, and that overall decrease in Medicaid enrollment. We're seeing just the population that's staying within Medicaid managed care and continuing to maintain their Medicaid eligibility is a sicker population. The next slide is, our final slide is our claim payment turnaround times. I do want to flag a concern here. We've seen a pretty significant increase in our aging. This happens typically at the end of the county's fiscal year as they roll over to the new budget. So we've seen an uptick. I think, you know, particular concern for us is some claims that are aging past 90 days. We've been doing a lot of work this month to push out claims payments back out to providers to sort of catch up on this. But this is, you know, something that we're monitoring really closely and working to get this out. The other dynamic that happens here is there's a appropriation limit we have each year in the budget. So sort of regardless of the amount of claims that we're receiving at any given time, we're capped on how much we can pay out on those claims based on that appropriation limit. So that dynamic tends to come into play at the end of the fiscal year. So in November, we start to hit that cap at the end of the county's fiscal year. And so some of that then transitions to get paid out in the new budget year. So we've been sort of trying to build in more flexibility into that process, and the county's been, I think, supportive of that to try to make this a little better each year. But, you know, I just would flag that, you know, we're not at a great point right now, and we're working to get caught up here in December, and hopefully we'll see these numbers come down. And with that, I'm happy to answer any questions.
Any questions for Aaron, please? Okay, I don't hear any. Aaron, thank you. Appreciate your report. Okay, we will now move to the, let's see, item 8B, Human Resources Committee metrics. And that's not going to be reviewed by Wayne. I assume he's in Paris in a cafe, maybe about now. So, yeah, exactly. We're going croissant. So we'll go with R.J. Dabney, Associate Chief Human Resources Officer. Oh, no, we don't have that. Just going by the script.
Over to you.
Sorry, Jerry.
No
Jerry,
worries.
we don't know you, please.
Carrie Pray-McWoke, Associate Chief Human Resource Officer, pinch hitting for both the people who are not here or on campus, and one of them not even in the country today. All right, I will make this quick. We've had a long morning already. This first slide is one you've seen, and as you can see, we are down to having our vacancies at 1,559, which is a significant decrease from the beginning of the fiscal year. 70% of those vacancies are within HR and in some form of the recruitment process, with more than 50% of that in the latter phases of the recruitment process, so nearing towards either an offer status or even onboarding status. Our vacancy rate, though, is currently at 20.7%, which is a significant decrease from where we were last year at the same time, which was at 26%. Next slide. Here are our key hiring metrics. We have made offers to over 2,000 individuals through the fiscal year 2025, which ended at the end of November. And 1,400 of those, a little more than that, were accepted. We also had 480 resignations, retirements, or separations from the organization, which is decreased from where we were last year, which was also decreased from where we were the last several years. So we are still trending downward on our separations, which is good, and that is a big boost to our employee engagement initiatives that we have been utilizing. And then our favorite number is the one at the very far right, which is our net new hires. We are significantly higher, over 170 more net new hires this year than we were last year, which is a 58% increase. And my final slide is on our nursing hiring metrics. The key highlights here are that we are still trending downward on their steps as well, year over year from last year and even the year before that, as well as our time to fill. Now, our net new hires are not higher than they were last year. We've had a couple of different initiatives this year which have slowed down that nursing onboarding and hiring processes, which we picked up in the fourth quarter, and so we expect those numbers to really translate in Q1 here in FY26. However, that time to fill just a few short months ago was 23 days longer, and so the team has made some real strides in speeding up that hiring and onboarding process for our nursing team so that we can get their vacancy rate down as well. And that concludes my report. Although, or no, it doesn't, I'm sorry. I did want to just make a couple of notes on that hiring fair we had earlier that Mary spoke to a little bit about how she was able to fill multiple of her vacancies. She actually filled almost all of her set vacancies that we set into the hiring fair, with only a few of them not being filled because offers were rejected. And we did have a ranked list, which we are going to this week. So we do expect that we should be able to fill almost all of her vacancies that she put into that hiring fair by the end of this year, and then onboard them in the January weeks. We had 178 people attend, so it was a very well-attended, well-received hiring fair, especially since we did advertise it as correctional health. So it wasn't a surprise to the attendees where they were looking to be working. It wasn't going to be on this campus, despite the location of the fair. And everybody was pretty excited. The energy was very good. I did get to visit it for a little while. And so that is the key to it, was getting the people in, as well as she has a very difficult position in her queue for trying to hire. We've had a large number of vacancies of our LPN positions for years. And with all of the positions for the LPNs that we put into the hiring fair, we were able to fill all but 2 of them. So that is going to be a huge stride for them and their patient care initiatives that they're trying to improve over there at the correctional center. So, and with that update, I am now done with my report.
Thank you, Carrie. Any questions? Yes, Director Aaron.
Yeah, I'm just curious because most of our employees stay and retire from the system. I'm wondering, is there a point at which we will see a flux of people? And I don't know what the ages are.
We do have an aging workforce, and we are currently going through the data to calculate if we're going to see a big bolus, more so than we usually do. That usual large number of retirements happens in December, so we will see those numbers increase come January. However, the fact that we have continued to trend downward actually, I think, can be correlated to the fact that those retirements are now happening at a later and later date. So we have seen an increase of the number of people who are staying past what would normally be their retirement dates, or the retirement dates they could enjoy, because if they have been here long enough, they actually have the ability to retire earlier than some of our staff as well.
It'd just be interesting to see what those numbers look like.
Yeah, we are looking at those.
Any other questions? Andrea, or Carrie, thank you. You screwed up your name 4 times.
That's okay. I'm everybody today.
Thank you, Carrie. moving on to the next item, the board will now be going into closed session, now to review, information regarding the 19 proposed CDA extension agreements. Action is expected to be taken when the board returns to the open meeting. So I, would like to ask for a motion to go into a closed meeting pursuant to the following exceptions to the Open Meetings Act. 5, ILC 120, /2, C1 2 11 12, and 17. And, Madam Secretary, I understand you'll need to take a roll call vote. So first, we'll need a motion.
So moved. Second.
Second. Did I hear a second? Next spot? Okay, second.
I second it.
Okay, sorry, my fault. Madam Secretary?
Roll call vote on the motion to go into closed session. Aye or nay? Director Bott?
Aye.
Director Green?
Aye.
Director Harrington?
Aye.
Director Kim? Aye. Vice Chair Lowry?
Aye.
Director Masuda Barnett? Aye. Director Ryder?
Aye.
Director Robinson?
Aye.
Director Sorrell is absent. Director Stain is absent. Director Webster Cross? Aye. And Chair Garza?
Aye.
You have 10 yeas and 2 absent.
Thank you, Madam Secretary. So we'll need a few minutes to clear the room, and then we'll be in closed session. Thank you to the staff. Thanks for all you do for the county.